Hello friends, Diuretics part 2. In this video, we will be looking at loop diuretics. Of course, we are not going to discuss much of pharmacology, but the physiologic basis of their action of loop diuretics, and of course, even the basis for their side effects, etc. So let's start. But before that, we need to revise two important physiological principles which we will require later on in the video. First, the diffusion by concentration gradient and by electrical gradient. Look, diffusion of ions can occur by concentration gradient. Their own concentrations drive that particular diffusion. So if the sodium is high on one side and low on the other side, sodium will diffuse by its own concentration gradient from high to low concentration. There is also the diffusion by electrical gradient or electrochemical gradient. Now this gradient is created by presence of all the cations and anions on either side of the membrane. For instance, if there are more number of positive charges on one side and less on the other side, then a cation like sodium or calcium or magnesium can diffuse from high number of positive charges to low number of positive charges, and this is diffusion by electrical gradient. In case of anions will diffuse from high number of negative charges to low number of negative charges, or an anion like chloride can diffuse towards the high number of positive charges. All right. So electrochemical gradient will drive a cation to go from high positive charge area to low number of positive charges, or an anion can be pulled in the opposite direction, meaning towards the high number of positive charges. This principle will be required in our due course of discussion. And the other principle of diffusion or movement is that there is transcellular reabsorption of substances, or there can be paracellular movement. Transcellular being that from the lumen the transport can occur like this. From the lumen, an ion can enter the cell through the apical membrane, and then from the other side, that is from the basolateral membrane, it leaves the cell and enters the blood vessel eventually. So that's one, and that's called as transcellular transport. Paracellular is between the two cells, between the two membranes. So like for example, parallel, it says paracellular will be like this. So it is not crossing the entire cell, but it is going between the two cells. That's paracellular transport, and we will see that paracellular transport is mainly driven by the electrochemical gradient. Yes, that's why we also discussed the electrochemical gradient, because electrochemical gradient will drive paracellular transport and reabsorption of certain cations. So with that in mind, now let's start our discussion on the loop diuretics. All right. Our focus will be on the thick ascending limb of loop of Henle, because that is where they act. The transporter NKCC, because these loop diuretics, they act on the NKCC transporter, sodium, potassium, chloride co-transporter. And then finally we will see the mechanism of action of loop diuretics and how they act, what side effects are produced, etc. So understanding the thick ascending limb of loop of Henle, action of loop diuretics, and the consequences of those actions, and the physiological basis of side effects. Let's begin. Now the first point is which we have already described in the previous video, that there are many categories of diuretics which stop the reabsorption of sodium. Sodium chloride reabsorption is prevented. Thereby sodium load to the distal part of the nephron is increased. Some of it may get reabsorbed, but eventually some is lost into the urine which is called as natriuresis, and resultant loss of water is called as diuresis. Now, sodium reabsorption is taking place in various segments of the nephron. 67% of the filtered sodium is reabsorbed from the PCT. So, if we had some diuretic which could stop this reabsorption, it would become a very potent diuretic because it is stopping almost 2/3 of the filtered sodium getting reabsorbed. But at present, we don't have such diuretic available which acts at the PCT and stops the reabsorption of sodium chloride. Next comes the sodium reabsorption in the other segments like thick ascending limb of loop of Henle, then the DCT, and then finally the collecting duct. At these places, sodium is getting reabsorbed. Now, out of the filtered sodium, 67% already gone in the PCT, 25% reabsorption is taking place in the thick ascending limb of loop of Henle, then about 5 to 10% in the DCT, and collecting duct about 2 to 5%. Now, consider this, that a diuretic which will act in the thick ascending limb of loop of Henle is going to stop almost 25% reabsorption of sodium and chloride. So it will have a huge capacity as a diuretic, huge efficacy as a diuretic. Compare that with the DCT, about 10%, collecting duct about 2 to 5%. So my point is, greater the sodium reabsorptive capacity of a segment, greater will be the diuretic acting on that segment. I mean, greater efficacy will be shown by a diuretic which is acting on that particular segment, isn't it? It will be preventing a greater amount of sodium chloride. That means the loss of water will be that much greater. Diuretic action will be that much more higher. So that's the basic point. About 20 to 25% of the filtered sodium chloride is reabsorbed from the thick ascending limb of loop of Henle. You know, loop of Henle, the descending limb and the ascending limb, initial part is thin and then later part is thick, which is where the diuretic action is going to be. And here the sodium, chloride and potassium are going to move. Sodium chloride are going to be reabsorbed. Let's see how the sodium chloride reabsorption takes place. Okay, now on the apical membrane, on the apical side, we have a transporter called as NKCC transporter. NKCC, that is sodium, potassium, chloride co-transporter. This transporter is said to be electroneutral transporter. Why? Because it binds 1 sodium, 1 potassium and 2 chloride. The co-transport is taking place as 1:1:2. I mean 1 sodium, 1 potassium, that's 2 cations, and 2 chloride, that's 2 anions. So it is an electroneutral transporter. In some time we will see that this is electroneutral yet electrogenic. We will see that in some time. Anyways, so sodium, potassium, chloride co-transporter is happening by this NKCC transporter. Sodium enters the cell. Now we all know that we've seen this in the previous video, that sodium transport out of the cell occurs by sodium potassium pump. That's a common feature in all the places in the nephron. In the basolateral membrane, there is sodium potassium pump. So the sodium that has entered the cell will leave the cell from the other side by use of sodium potassium pump. All right. Chloride also has its transporter which will cause chloride to be reabsorbed. So sodium and chloride are reabsorbed from this particular segment, thick ascending limb. We are talking about the physiology. We have not yet reached the action of diuretics part. Now coming to the fascinating part, and that fascinating part is potassium recycling. Yes, you heard it right, potassium recycling. Look, this transporter is causing reabsorption of sodium and chloride. What about potassium? Potassium also entered the cell. What happens to it next? Well, yes. What happens is this potassium does not leave the cell from the other side, and it is not reabsorbed into the blood. Because on the other side of the cell, on the basolateral membrane, there is sodium-potassium pump. And sodium-potassium pump does what? It removes the sodium from the cell and brings the potassium into the cell. So, from the other side, potassium is being brought back into the cell. And there is no way potassium is moving out of the cell and getting reabsorbed. So, what's happening here is that potassium from the lumen entered the cell, but it does not leave the cell. In fact, more potassium will be brought back into the cell via the action of sodium-potassium pump, which means intracellular potassium concentration rises. And since intracellular potassium concentration goes on increasing, potassium simply diffuses backward. See, the potassium initially intended to move from the lumen into the blood, but it does not happen. In fact, from the other side also potassium is getting dumped inside the cell, and therefore potassium concentration goes on increasing inside the cell, and because of that there is back diffusion of potassium from the cell into the lumen. This has been described as potassium recycling. What is the benefit of this? The benefit is there is more potassium again available to bind to this NKCC transporter from its luminal side. So that's the advantage of this potassium recycling. Now, what happens as a result of this potassium recycling? Because of the potassium getting secreted back or moving back into the lumen, positive charges are getting accumulated on the outside of this cell. Let's draw a diagram to illustrate this. Potassium was pumped back into the cell as sodium was sent out and it was reabsorbed, and from this potassium shows back diffusion into the lumen again. So this has been called as potassium recycling. It's simply going out then coming back into the lumen. All right, now because of this potassium, positive charges, they accumulate just outside the membrane in the lumen of the tubule. So this is called as lumen positive potential. Lumen is having a tubular lumen is having extra positive charges, creating a positive potential. And now this positive potential is going to be the driving force, as we have mentioned previously, for the reabsorption of calcium and magnesium. Calcium and magnesium will be driven because it's a positive potential in the lumen, in the tubular lumen. So these cations, they are driven out by the electrochemical gradient via a paracellular pathway. So the points to be remembered is that calcium and magnesium are reabsorbed from the thick ascending limb of loop of Henle, point number 1. They are driven by electrochemical gradient, which is created, by the way, by the movement of potassium, like this, by the back diffusion. So potassium is driving the reabsorption of calcium and magnesium. And third part, calcium and magnesium are getting reabsorbed by paracellular pathway, not the transcellular one. So now just I'll make a mention of loop diuretics. what their effect is going to be. They will bind to the NKCC. That means they will stop the transport of sodium, potassium and chloride, and then all the further events are also prevented. That means they will stop the reabsorption of calcium and magnesium. So what happens with the action of loop diuretics is the calcium and magnesium are transported. They are going to the distal segments of the nephron. Now calcium and magnesium could have been lost into the urine. With calcium, there is a little advantage that in the later segments in the DCT collecting duct, there are transporters, active transporters for the reabsorption of calcium. So calcium will not be lost into the urine, but magnesium cannot be reabsorbed after this. Magnesium is lost into the urine. So with the action of loop diuretics, there is a possibility of hypomagnesemia. Magnesium is decreased in the plasma. It is lost into the urine. There could have been hypocalcemia as well, but it doesn't happen because calcium, although it could not be reabsorbed from this part, there are transporters in the distal nephron that can cause the extra calcium reabsorption. So the point to be highlighted here is that the NKCC, I call it electroneutral as and yet electrogenic transporter. And why do I say that? Because while it is transporting two cations and two anions. In that sense, it is electroneutral. But eventually, by virtue of this back diffusion of potassium, it is going to create electrogenicity with more positive charges lined up in the tubular lumen. So electroneutral yet eventually electrogenic type of a transporter. And as I mentioned, potassium recycling is unique to this segment. It doesn't happen anywhere else. Please note it down that potassium recycling is very unique to this particular segment. And it creates lumen positive electrical potential. Yes, again the highlight of this segment is that lumen positive, that is just outside the cell, in the lumen of the tubule there are positive charges accumulated, and we also saw the result of that, that is reabsorption of calcium and magnesium, the cations. All right, with that in mind, now let us talk about the loop diuretics. Point number 1, they act at the loop of Henle, thick ascending limb of loop of Henle, so they are called as loop diuretics. Simple. They are described as high ceiling diuretics. Now this needs a certain understanding. Why are they called high ceiling diuretics? Look, diuretics are preventing, many of them, they are preventing sodium chloride reabsorption, and thereby they are causing natriuresis and diuresis. We have discussed this already. Consider the other diuretics. Let's say thiazide diuretics or the other diuretics. The point that I am trying to make here is the ceiling effect. Let's say some other diuretic, it is causing the reabsorption of, it is preventing the sodium chloride reabsorption by binding to the transporters which are available. Some other diuretic acting at some other segment of the nephron. And let's say these are the transporters available for reabsorption of sodium chloride, and the drug, if you give it as a certain dose, it binds with these transporters and stops the reabsorption of sodium chloride. If you increase the dose, it further binds to more transporters. Sodium chloride reabsorption is further prevented. That means the diuretic action will be further increased, enhanced. Further increase the dose. Now it has bound to all the transporters available. all the carriers of sodium and chloride. The drug has bound as you increase the dose, and diuretic potency or efficacy has reached its maximum. So that means the drug efficacy has hit the ceiling. It can't increase its diuretic efficacy beyond this because it has already bound to all the transporters. So even if you increase the dose, it has no further capacity to stop the sodium chloride reabsorption any further. It has reached its maximum. All right, so it hit the ceiling. Now in this context, we are talking about loop diuretics as high ceiling diuretics. That is, they have a ceiling which is higher up. They will hit the ceiling later because of the reason that the thick ascending limb of loop of Henle has got a much greater capacity to reabsorb sodium chloride. We saw this, that in this segment 20-25% of the filtered sodium chloride is getting reabsorbed. In the DCT, only 5 to 10%. In the collecting duct, only 2 to 5%. So the first point is that this segment, thick ascending limb of loop of Henle, has a much greater capacity to reabsorb sodium chloride, right? Let's say these are the transporters, NKCC, in that segment of the nephron, the thick ascending limb of loop of Henle. Much greater capacity to reabsorb sodium chloride because high number of transporters. So when you give loop diuretics, let's say we start with a lower dose. They will bind to the this NKCC transporter, sodium chloride reabsorption inhibited, sodium lost into the urine. If you increase the dose, further reabsorption of sodium chloride will be inhibited. That means the diuretic efficacy will be further increased. More diuresis will occur. You further increase the dose, it will further bind to more and more transporters. What's happening here? The capacity of the thick ascending limb is much higher because more number of transporters are available here. So you go on increasing the dose of loop diuretics, then it can inhibit more and more sodium chloride reabsorption. Eventually, it will also hit the ceiling when at a particular high dose, all the transporters have been saturated. But that ceiling is high compared to the other diuretics and their blockade of sodium chloride reabsorption. So this is one reason why they are called as high ceiling diuretics. The other reason is that their action is not limited by, say, acidosis. There are certain other diuretics like carbonic anhydrase inhibitors. They result in acidosis, and that acidosis limits the action of those diuretics. That's not the problem with loop diuretics. So because of these reasons, they are said to be high ceiling diuretics. They hit the ceiling at very high doses, but before that their efficacy goes increasing with your increasing dose. So high ceiling diuretics. Let's see the mechanism of action. Yes, this is another important aspect that needs to be understood. Look, the NKCC transporter is on the apical membrane facing the lumen. So the drug has to go there to bind with that transporter, right? The loop diuretics, they are secreted from the blood into the tubule in the PCT. And by this secretion, they will travel in the tubular fluids like this, and they will reach the NKCC from the luminal side. So normally, I mean, why it is special? Because normally any other drug, when it is given, it will absorb into the blood. Via blood stream, it will reach the target area. This drug is not reaching the target transporter or target area via the bloodstream, it is reaching via the tubular fluids. So point to be noted, loop diuretics are secreted and so are other substances. Organic acid secretory systems are present in the S2 segment of the PCT. So uric acid, then NSAIDs, diuretics, even antibiotics are secreted from the S2 segment of the PCT, and they are secreted into the tubular fluid. And in the case of loop diuretics, they travel through the tubular fluids and they reach the thick ascending limb, and they will bind the NKCC transporter from inside, means from the luminal side. And once that happens, sodium chloride reabsorption is prevented. That means sodium and chloride are now not getting reabsorbed, they are traveling further to the distal part of the nephron. So inhibits the NKCC, it stops the sodium chloride reabsorption, and also, now this point again to be noted, they will also diminish the lumen positive potential. It was the NKCC transporter which was eventually generating that lumen positive potential. By blocking the action of NKCC, the loop diuretics diminish the lumen positive potential. What will be the effect? Increased calcium and magnesium excretion. Remember, we said because of the lumen positive potential, calcium and magnesium were driven out by the electrochemical gradient. But that's not happening. So it results in hypomagnesemia. As I mentioned, magnesium lost into the urine. But it does not cause hypocalcemia, because calcium can be reabsorbed from the later parts of the nephron. However, loop diuretics can be used in the conditions of hypercalcemia. Yes, in the conditions of hypercalcemia, the loop diuretics can be used to cause a rapid excretion of calcium. So calcium can be removed to certain extent. It does not cause hypocalcemia, but if there is hypercalcemia, then the action of loop diuretics can cause removal of some amount of calcium into the urine, and thereby it helps in hypercalcemia. I tell you, hypercalcemia is a potentially dangerous condition because the calcium can get deposited in various important organs. So a rapid removal of calcium is sought in certain in the conditions of hypercalcemia. Loop diuretics can help there. So mechanism of action, basically how it is reaching the target site, and also it is known to increase the renal prostaglandin synthesis. The loop diuretics are known to cause, well, I have not mentioned the name so far, but the loop diuretic, the prototype drug is Furosemide. It's called Furosemide, it's also called Furosemide, the trade name is Lasix. So Furosemide, it increases the renal prostaglandin synthesis and also increases the renal blood flow. So these are some of the known actions of the loop diuretics. Finally, with all this in mind, we will see it is indicated in what conditions, like acute pulmonary edema. Now obviously it is a diuretic, so it will be used in the conditions where the fluid has been retained. So acute pulmonary edema and other edematous conditions. Hyperkalemia. Yes, hyperkalemia is one condition, because we need to discuss this in detail. That so far we said that the sodium chloride reabsorption is prevented by the diuretics. So more and more sodium is sent to the distal segments of the nephron, and therefore, let's say in the DCT and in the collecting duct, the sodium load for reabsorption is increased, and more the tubular load for sodium reabsorption, more will be the potassium secretion. Yes, in the collecting duct as elsewhere in the body, sodium, most places, sodium and chloride go in the opposite directions. So more the sodium for reabsorption, more will be the potassium secretion, and potassium will be lost into the urine when these diuretics are working, particularly loop diuretics and thiazide diuretics. So in the conditions of hyperkalemia, the loop diuretics can be used because they cause secretion and excretion of potassium into the urine. All right. Okay. What else? What other conditions? Hypercalcemia, we already saw. Hypercalcemia, the loop diuretics can cause increased excretion of calcium. Then acute renal failure, anion overdose. This condition also needs to be explained. There are certain toxic anions, if they are ingested, they are reabsorbed from the thick ascending limb of loop of Henle. The toxic anions, bromides for example, and they can cause overdose and toxicity. So the loop diuretics, by blocking that NKCC transporter, can also block the reabsorption of those toxic anions like bromides, and they can be lost into the urine. They will be lost into the urine. So in that condition, okay. Side effects and toxicity. Side effect: hypokalemic metabolic alkalosis. So remember, carbonic anhydrase inhibitors were eliminating HCO3 minus into the urine, and therefore they were causing acidosis. These drugs, they are causing metabolic alkalosis. Why? Because they are causing loss of hydrogen ions in addition to potassium. Look, what happens here is, if in the collecting duct there is more sodium load for reabsorption, then in exchange by the principal cells. There are two cells, principal cells and intercalated cells. So principal cells reabsorb sodium and secrete potassium. So more the load for sodium reabsorption, more will be a secretion of potassium. That means for the intercalated cell, which reabsorbs potassium and secretes potassium, it will have more potassium to reabsorb and more H plus to secrete in exchange for that. That means H plus will be eliminated into the urine, and H plus lost means alkalosis. So these drugs, they cause hypokalemic alkalosis, loss of potassium, loss of H plus. Although potassium is getting reabsorbed by the intercalated cell, but it's a huge load, so some of the potassium is definitely going to be lost into the urine along with the H plus. Hypomagnesemia, we have done that already. We saw that in the discussion. Hyperuricemia, yes, that's another side effect. You know, these loop diuretics, the furosemide, it decreases the circulating blood volume because it causes loss of volume into the urine. And because of the hypovolemia, it increases the uric acid reabsorption. Uric acid reabsorption, you know, from the PCT S2 segment. So this increased uric acid reabsorption is actually linked to the hypovolemia, which is caused by the furosemide, by the loop diuretics. And therefore hyperuricemia is another side effect. So let's now come to the conclusion part of this. These diuretics, they produce a major side effect, that is hypokalemia. Hypokalemia can be life-threatening, it can be dangerous. So since hypokalemia is such a serious side effect, there was a need to develop the drugs which could spare the potassium. Those drugs would not cause a loss of potassium into the urine. So there was a need for potassium sparing diuretics. Spironolactone or other diuretics, they are called as potassium sparing diuretics because they will not cause potassium to be lost into the urine. Their action will be in the collecting duct, and that is what we will discuss in the next video. But that was, in a summary, the action of loop diuretics, furosemide, and the physiologic basis of the action of furosemide.